which include transitional housing, shelters and emergency recipient sites, food access service, job training and counseling, health information and community services, community mental health outreach, and specialized support programs. But my colleagues here are best suited to speak to their incredible and important work mentioned here and other programs that offer by Third Vector. Today, we gather to share insights, learn from each other, and forge strong partnership so that together we can create sustainable solutions, not only provide immediate relief, but also pave the way for long-term stability and empowerment for women facing homelessness. This is our mission, to make it the issue that creates homelessness cease to exist. I thank you for being here, for your commitment, for your passion. I look forward to the fruitful discussions and collaboration that will emerge from this event. I have hope that our work is necessary and needed, and I can't wait to be in community with you to make it happen. Thank you very much.
Thank you, Dr. Eamon, for those inspiring words and for sharing some of the work that Fred Victor is doing, which is truly inspiring, and building our communities to ensure that no one is left behind. We will now go into our plenary sessions, and I am honored to have 3 speakers from Fred Victor. As I introduce you, if you can please come and sit here in the panel seat. Sherry Hayes, who is the Senior Manager, Quality Assurance 24-Hour Services at Fred Victor. Sherry was originally hired as the manager for Fred Victor's transitional shelter for older women, now known as Mary Sheffield House, in 2016. She later took on the senior manager position for the women's 24-hour drop-in and then moved into her current position about 3 years ago. She has been working in the nonprofit sector for over 35 years, and specifically with women experiencing homelessness for over 18 years. She is passionate and advocates for gender equality and human rights. Sharon.
Good morning, everyone. Gonna wait for a slide presentation, but that's okay. I can start.
No, just wait.
Okay.
She's gonna.
That's okay. I'm going to say a few things that actually aren't on the slides, so that's not a problem. As Ilda introduced me, my name is Sherry Hayes. I currently work for Fred Victor Center, and I've been working in nonprofits for over 3 decades. And my very first job in this sector was as a frontline worker in an emergency shelter for women in 1986. I don't tell you that to impress you. I want to explain the bags under my eyes and the gray hair. So, okay. Let's see if I can figure this out. Great. So since that time of my very first experience as a frontline staff, which was, to say the very least, exceptionally eye-opening, a lot has changed since then in the sector, and a lot hasn't. Certainly there's been some very positive movements in terms of our best practices and how we work with folks within the emergency shelter system. What hasn't changed is, are the systemic issues that create the situation of homelessness, in particular for women and gender diverse people. Those systems have not changed. The housing crisis has not changed. It's gotten worse. So it's been interesting for me to look back and just evaluate what's happened over the years. Right. A few stats. We get a lot of statistics. A few that I wanted to highlight. Indigenous women and girls and 2S LGBTQIA+ people encounter disproportionate amounts of violence directly due to the lack of affordable, safe housing. Multi-marginalized women, girls, trans people, and gender diverse folks are at greater risk of homelessness and/or housing instability. One of the primary reasons that women and gender diverse people stay in or return to abusive situations is the lack of safe, affordable housing. Current stats show that 1 in 5 will return to an abusive situation. This statistic still just astounds me whenever I read it, whenever I say it. Approximately 699 women are turned away from violence against women shelters every single day in Canada. To still give me chills when I say that. And that number doesn't include the children that accompany them. 699 women every single day. 90% of families using emergency shelters are led by single women. And Toronto Public Health data shows that over 120 homeless women give birth in Toronto every year. Just a little bit about Fred Victor Centre, and I may repeat some of what's already been said. Over the years, Fred Victor Centre has evolved in response to the needs of the community and to provide vital support to the city's most vulnerable residents. We've now expanded our programs and services to over 25 sites, 25 locations across the city of Toronto. Our vision of healthy and thriving communities where every person has a home and access to opportunity is one that is rooted in over 130 years of history, and one that continues to drive our vision today. As we increasingly focus on developing safe, affordable, and supportive housing, we continue to strive to meet the needs of the 10,000+ individuals who are houseless every single day on the streets of Toronto. The 24-hour services department, which is where I work currently, operates 7 emergency shelter and respite programs with an 8th that is a temporary winter emergency shelter. We do this with direct funding from City of Toronto, Province of Ontario, and supplemental funds raised by Fred Victor, and with the collaboration and partnerships of many organizations across the city. Right. There we go. Our department within Fred Victor employs about 220 staff who work in various roles, everything from case managers, housing workers, intake and assessment workers, cooks, shelter support workers, harm reduction workers, peer support workers, eviction prevention and follow-up workers, and management and administrative staff. Our emergency shelters and respites provide shelter for 687 people every single night and their pets. So just to, some information about the 4 emergency shelter programs that are specifically for women and gender diverse people. Each of them are unique in some way, but they share some common elements. They all provide basic services: shelter, food, showers, laundry, clothing, hygiene and harm reduction supplies, and 24-hour staff support. They all provide case management services, which includes support with securing more permanent housing. They all provide crisis counseling, mental health and substance use support, social, recreational, life skills programming, and referrals to other programs and services externally and within Fred Victor's other programs. We strive to provide our services that are client-centered, that are trauma-informed, from a harm reduction framework, that are strength-based, that are anti-racist, anti-oppressive. Each program has unique partnerships that strive to work collaboratively to support our service users in the best way possible. Some of these include CAMH, a shared care program, Sherburne Health, Street Health, Loft Community Services, and Anishinaabe Health. And we continue to seek new partnerships and collaborations on an ongoing basis. So a little bit about each of the individual programs for women. So Fatima House, also known as Women's Hostel, was opened in 1997. It was originally on Lombard Street in an older historic building. More recently, we moved to a lovely renovated space on College Street. It's currently a 52-bed emergency shelter that offers mostly individual rooms with private ensuite washrooms. In 2023, we served 59 individual women through that program. Women can self-refer, walk-ins are accepted if there's space, which is rarely. Most referrals come through the city's central intake. Follow-up services are offered to each resident when they leave the shelter to move into more permanent housing for up to 1 year. And follow-up services can include crisis counseling, referrals to other supports, and eviction prevention. And Mary Sheffield House, this was the program that I originally was working in when I first came to Fred Victor. It was formerly known, we have a lot of programs where names have changed over the years, which becomes very confusing for folks because we will use both names and it just gets confusing. Mary Sheffield House originally was the transitional shelter for older women. So it opened as a result of the recognition that there was an increasing number of women who were aging in the shelter system. The 2018 needs assessment showed there was a 40% increase of women 55 and older living on the streets or in precarious housing since 2013. So this particular transitional shelter serves women over 55 who are particularly vulnerable due to complex physical, mental health, developmental and or substance use related issues. There is an application process for this program, and geriatric case management, housing services are provided. And again, these are individual units with ensuite washrooms. The general length of stay here is 1 year, but there's flexibility in that. As we recognize, again, the challenges of moving folks into permanent housing that doesn't exist. In 2023, we served 37 women through that program. So the Women's 24/7 drop-in has had quite a metamorphosis over the years. It originally operated as a Monday to Friday, 8:30 to 3:30 drop-in under the umbrella of the Adelaide Resource Centre for Women, which is operated by the City of Toronto. In 2013, there was a very horrific incident that happened where a woman was sexually assaulted, raped, actually, twice in one night as she was trying to find rest in the doorway of Street Health. And from that, there was this recognition that there were women who were not being served because they weren't able to access shelter space in the middle of the night. They required services that were very low barrier. And so from that, 2 24-hour drop-ins for women were created. And they were the first in Canada, to my understanding. One was the Fred Victor, the one that we operate, Fred Victor, and the other one is Sistering. And so it's a very low barrier program. People can come and go, all hours, day, night, doesn't matter. Come in, you don't have to tell us who you are, give us a name, just what do you need, right? and access to basic services, food, shower, hygiene supplies, harm reduction supplies. There are many partners on site, including healthcare, employment training services, life skills program. And then in 2018, when the emergency shelter system was literally bursting at the seams, the city approached us about opening up 30 overnight respite beds in the building. It's a very large building and there was some unused space, and to help deal with the shelter occupancy crisis. So we did that. And then the pandemic happened and it changed how the drop-in operated. And it's become more aligned with an emergency respite model of shelter. Walk-ins are accepted when there's space for the overnight respite, but generally referrals again come through central intake. And again, case management services, including housing help, continue to be offered there. In 2023, the Women's Drop-In had over 20,000 visits and served 374 women in its overnight program. Sorry, oh, thank you. And our other transitional program for women is the Women's Transition to Housing on Dundas. And it's a 37-bed transitional shelter that is that diverts women who've been homeless for less than a year. So the hope here is that we are assisting women to not get caught in the emergency shelter system, because that does happen. And there's an application process for this program as well. And rapid rehousing is the goal, so that women don't experience the mental and physical deterioration associated with long-term shelter use. And again, each woman has their own room, own washroom. At this location, we have a formal partnership with Anishinaabe Health, Toronto, and reserve 5 units for Indigenous women. And in 2023, we served 74 women in that program, 25 of whom moved on to permanent housing. And working with diverse communities. So working with refugee and immigrant women in Fred Victor shelters programs. So there are a number of refugee shelters in the city of Toronto, but they are increasingly at full occupancy. And our shelters are receiving a greater number of refugee and immigrant women than ever before. We've had to quickly adapt to this changing demographic that requires very specific knowledge and skill sets to effectively support these women. And a current trend that we're seeing are many, often quite young refugee women who are pregnant and on their own and ending up in our emergency shelter system. And working with gender diverse people, there's no specific services for transgender or those identifying as gender diverse non-binary in the shelter system, with the exception of youth shelter Friends of Ruby. Fred Victor has a long history of working with vulnerable women, including trans women and those identifying as gender diverse. And all of our shelter programs welcome folks from the 2S LGBTQ+ community. There are particular challenges faced by this community: discrimination from employers, landlords, healthcare professionals, social service workers, justice system, et cetera, very limited services in the sector to support their needs, estrangement from family, friends, community. They're more likely to have mental health, substance use issues basically due to the discrimination they face, more likely to live in poverty, and are at increased risk of gender-based violence and hate crimes. And there's limited access to trans health services. I also just wanted to say a word about Indigenous women in homelessness, and I took this quote directly from the Women's National Housing and Homelessness Network, Women and Girls Homelessness in Canada. And I thought it spoke just very clearly to the situation. So directly linked to ongoing colonialism and genocide being committed against Indigenous peoples. Colonial structures that began in the 1600s continue to dehumanize and oppress Indigenous women, subjecting them to poverty, rape, sexual violence, and murder. Colonialism creates the conditions for homelessness and housing need amongst Indigenous women. Some factors that contribute to women's homelessness, and we could spend several weeks talking about these, but I'll just highlight them, and I'm sure you're all already aware. I think poverty, in my opinion, is number one. Racism, also right up there. Ableism, homophobia, transphobia, trauma, ageism, gender-based violence, unsupported mental health and substance use issues, sexism and misogyny, patriarchal systems, and colonialism. Some of the resources I used. And that's it from me. Thank you.
Thank you very much, Sherry. Wow, that was a lot of information and so important. That was wonderful. Thank you very much. It's truly amazing the work that Fred Victor is doing and all the programs and services that are being facilitated by these many diverse groups. We will have question and answer discussion afterwards, so we'll leave those until the end. I would now like to introduce our next speaker, Vesna Milinkovic. Vesna is the director of the Health Services Department at Fred Victor. The programs in her diverse portfolio address the complex needs of individuals with severe and persistent mental illness in community settings, the intersection of mental health and justice, and access to services for people with concurrent disorders and dual diagnosis. Vesna is a GTA-based registered psychotherapist and a leader in community health care and social services. She holds a Master of Health Science in Health Policy, Management, and Evaluation from the University of Toronto. Vesna has been in leadership roles in the community mental health sector, 24-hour crisis services, and social service agencies in Toronto for over 20 years. Vesna.
Good morning, everybody. It's lovely to see you here and discuss these important topics. So today I'm going to talk about integrated models of care for housed clients with mental health issues. And some statistics first. 1 in 5 Canadians experiences a mental illness in any given year. By 40 years of age, 1 in 2 Canadians will have or have had mental illness, serious mental illness. Young people and lower income people are more likely to experience mental health issues. If left unaddressed, the impact of mental health conditions on lost productivity will cost Canadian businesses $198 billion over the next 30 years. This is pre-pandemic stats. We don't have the updated stats, so you can imagine this number goes up. Health Services Department at Fred Victor Center, like Ida has said, is a diverse and rich portfolio of community-based mental health and addiction programs for youth, adults, and seniors in Toronto who are housed, who are underhoused, or homeless, and who are dealing with severe mental health illnesses, concurrent disorder challenges, dual diagnosis barriers, justice issues, and difficulties functioning in their community. Health services are a recovery-based service, which means we're a client-centered service. that rely on evidence-based interventions to address unique needs of each client. And we use a variety of community-based models such as case management, short-term and open-ended, critical time intervention, drop-in, and integrated models with housing. Before pre-pandemic time, we had a peer and client group recovery project where we had our clients define recovery for them over a series of focus groups. And what they came up with is that recovery is a uniquely personal process that involves the development of new meaning and purpose in one's life beyond the limits of mental health challenges. The recovery process is driven by the individual. It builds on family, culture, community strengths, and enables people to enjoy a meaningful life in their community while striving to achieve one's full potential. For me, as a leader of health department, this is my vision too. So the programs that we are offering within the department are mental health case management in Toronto and Scarborough, justice case management for individuals with low-level offense, for whom it is determined that their mental illness and addictions have had something to do with the criminal charge. Then mental health concurrent disorders case management, which is for individuals who have barriers with mental illness and addiction. Also early intervention for individuals, for youth with early or first episode of psychosis. We have housing with partnerships, partnerships with housing, Toronto community housing, and in downtown Toronto, as well as in Scarborough. There is mental health diversion and core supports program for people that for whom it is determined that if they choose to do so, they can engage in accepting community supports as opposed to spending time in jail. Dual diagnosis programs for individuals who have developmental disability as well as barriers of mental illness. Mental health psychogeriatric program in St. Jamestown, partnership with Enhanced Bail in Toronto, community access services for individuals in St. Jamestown, health promotion, and partnership with Seamless Care Optimizing Patient Experience, which is a group of primary care physicians teams in Toronto. So the reason I'm listing all these programs like this is not only to tell you what health services apartment delivers. I want to make a point that homeless population and poor people are not a homogeneous population, and it takes all kinds of services in housing to support them. Housing itself, for many of our clients, is not enough. It is a wonderful start. It is home. It is a house. But to become a home, many of our clients need a very diverse, individually tailored services in order to prosper in their community. Going back to that recovery definition, it is an individual approach. It is an individual experience. We offer services in these locations, but I want to highlight that most of the work is performed in communities other than Fred Victor centers. So our staff actually go where people are as opposed to bringing them to our locations. The core components of the community model of service is performing needs assessment, which means collecting information about the client from their housing provider. Of course, we consent, collecting their health information, but most importantly, interviewing the client to see their subjective experience, their own barriers, their own strengths, what they would like to do. We engage people in crisis and safety planning, which means what happens for people when they're not well. Sometimes people say to us, they get very angry, and there is a level at which normalize emotions and remove a barrier for individuals not to be seen in the community as unsafe. So that calling the police or emergency room is an understood protocol for individuals so that we're not breaking relationships. We offer a transition plan from the service, and how does that look like? Once we leave, how individuals are going to live independently in the community with what support, so that we're not a service on and into itself. We focus on staff competency and clinical supervision, ongoing training for staff and service providers. These are some of the evidence-based practice. I will not spend so much time on them because Sherry has already mentioned many of these practices. I want to underline permanent supportive housing as one of the evidence-based practice. I know sometimes in the society we think is a nice to have. It is actually an intervention that has been evidenced to be the best course of action for individuals that need high level of support. Taken from Erickson and Page, how we build relationships is a foundational to health services. Treating people with positive regard, working with their perceived needs, providing incentives, letting clients set the pace of the service whenever possible, communicating effectively, both verbally and non-verbally, reliably and with consistency, and being creative. These things sound like a common everyday thing. They don't sound like a rocket science. Having said that, it is really important to underline the level of engagement with clients, because sometimes those situations can be stressful, and great amount of care and training goes into building relationship and keeping them intact. We cannot do our work without partnerships and collaborations. And I will not go through every partnership we have, but I can tell you there are very many. I will highlight concurrent disorder support services at Fred Victor. It is referral and access point that leverages formal partnerships with over 44 organizations for the purpose of clients gaining access to primary care, addiction medicine, psychiatric consultation, psychoeducational and therapy groups, withdrawal management, substance use treatment, counseling, transitional case management, and housing income and support. This program started 10 plus years ago. It is still very relevant. It is a very low barrier access where agencies realize that we don't have a very good way of providing people with addictions and mental illness timely access to services in Toronto. Agencies got together to pull the resources, and our concurrent disorder support services were born out of that. We also engage in partnerships to close gaps in services and particularly partnering with housing providers, including our own organization at Fred Victor, but also Mainstay, TCHC, in order to provide integrated model of care. Talking about that, I keep on promising. So this is in one picture, an integrated model of care at Fred Victor for one of our buildings at 40 Oak. The needs assessment was done for the building, and it was identified that there are multiple challenges that tenants have been facing with respect to eviction, substance use, overdose, with respect to just not having a good quality of life, emotional distress, and various other identified needs of the tenants. So the housing support was matched with mental health and addiction case management. I will go back. And one thing that we have done is very early on is identified staff roles. And that was really important because traditionally in the community models, those roles have been blurry and not really well defined. So we identified that mental health case management will ensure that coordinated care plans are completed, that all clients are referred to case management, and the mental health case managers took on ownership to support communication and coordination of all in a circle of care. They drive NECCP activities forward with the client with mental health, income supports, and social connections. They support needs as per their clinical judgments. They help arrange for housing related service to come if needed, for example, extreme cleaning, and they transition clients as appropriate, and they see clients at a drop-in case management as needed. And then housing staff, their role was determined as taking care of the building and the landlord needs. And so that left them with a lot of time to devote to the building and the facility needs, to respond to the real time and the building crisis, and building dynamics and tenant conflicts. So that freed up their time to actually do what they're supposed to do, which is attention to housing without having to kind of go back and forth in between the client tenant needs and the building. And what was important also to define where is that sweet spot where the staff roles overlap. So going back to the model, to the CCP implementation, drop-in and tenant engagement services, the staff are doing joint intake and the coordinated care plan developed. It's important that also the team that is in the building is connected to the external supports. Creating a formal partnership with healthcare providers, personal support network, and any teams that are determined to fill the gaps with respect to the client needs in the building. So those permanent partnerships become very important for the building. I wanted to focus on briefly on client outcomes. The most immediate results were seen upon implementation and 6 months into the actual project. And between January and June 2023, 21 clients were supported. All of the tenants have had housing and no tenants have been evicted. So there was a backlog of eviction notices that were cleared. There were no failover doses for the duration of that period. One client graduated from PSW course and found meaningful employment. 4 clients were connected to primary and psychiatric care, and 1 client registered for college. So what happens is oftentimes when integrated model is set up, there is a period of really increase in positive outcomes for clients. And then what is reached is the plateau, so to say, where the building is kind of stabilized. And oftentimes what happens is that is when the support services are sometimes removed. And that is often what happened in these integrated model. And then that kind of goes for a while. And then the tenant needs again start rising and then there's a dip. So it is really important, and this is something that we're looking into right now, because the building is stabilized in that sense that, you know, what is the sweet spot of services? It may not be needed to be as intensive as it once was, but to create some sort of a level of support where tenants feel that they can access appropriate services at the right time. So I just wanted to highlight that because oftentimes we see our housing, we hear our housing partners say, you know, well, there was support first year, but then they left and now we're stuck, right? Mm-hmm. This is another conceptual framework for aging in the right place. This is something that we use in our psychogeriatric team as a model of care, where you know, what is really important is to build environment of housing unit and surrounding neighborhood that is, and for its foundation, there's the stability and affordability of the place. That we offer on-site resources, but that we also outreach to off-site resources and bring them in where the clients live. So that people can feel a sense of control, that they have a choice and sense of their own autonomy, that they're satisfied and where they feel that their privacy and safety is protected. House is not a home. Emotional place and attachment to the house is a home. And that is an ingredient that we try our best to bring to our clients. We always need to be aware of the political and economic context within which we work, so that we're able to gauge the needs of our teams, that we're able to apply to the right funding, to be able to advocate for our clients, to advocate for our services, and provide the results in order to attract new funding for the community supports. And the last slide, challenges in moving forward. People with serious mental health conditions are disproportionately affected by homelessness. Stigma or discrimination still exists, and it's attached to mental illnesses. And it presents a serious barriers, not only to diagnosis and treatment, but also acceptance in the community. And we see that very often, that there is lack of understanding of mental illness once people are housed, and oftentimes they're treated as undesirables or dangerous. Housing designated for people with mental health conditions can contribute to significant cost savings in the health system. We all know that anecdotally, but it goes on to say it costs $486 a day, which is $177,390 per year to keep a person in a psychiatric hospital, compared to $72 per day or $26,000 per year to house a person in the community with supports. This is the last stats that we were able to get. We're hoping to have a more updated numbers. I'm sure these numbers went up. Once depression is recognized, help can make a difference for 80% of people who are affected. So that is a really important to note that many people suffering in silence. It is really important to speak up about health, about mental health, and receive supports, because prognosis of recovery are actually pretty high. Thank you so much.
Thank you, Vasna. Yes, those figures are very high, and I can imagine that after COVID, they were even much higher. And I'm actually interested in part of the Q&A to perhaps get a better understanding of what it was like pre-COVID and then post-COVID, and how our shelters able to adapt to those huge changes and the increased numbers, and what those impacts were. Because I know for a fact that there was a lot of evictions during COVID. There was a lot of lack of support systems, simply based because we had to be within our homes, and how shelters were able to deal with that. I would like to now ask Decca Farah to come up. Decca is the Director of Housing Access and Support Services at Fred Victor. She has worked extensively in cross-cultural service delivery and health equity. She is a researcher, trainer, and facilitator. Decca has presented at local, national, and international conference, cross-cultural mental health and community research that focuses on health equity and service access. She has been working with marginalized, vulnerable individuals over the past 20 years in the areas of cultural competency training, mental health and addiction, program and organizational development, as well as program coordination, research, planning, evaluation, and leadership building development. Decca?
Thank you very much. So the program that I will be talking about is Hostel Outreach Program, or a HOP, which is a program that serves women 16 and over who have serious mental health challenges and who are unable to cope in the community as a result of their mental health challenges. So there are the women who you see on the street corners, panhandling. They're the women who generally are turned down from shelters and hospitals, and they're in and out of hospitals. They're in and out of, they have a lot of interaction with the criminal justice system. They have a lot of interaction with institutions. There's a great deal of trauma, complex trauma, that often is added and multiplied when they live on the streets. Some of we've seen some changes about the population that we serve after the pandemic. We've seen, for example, individuals who are were living at home and being taken care of their parents who aged and maybe went to long-term care or developed dementia, and then the woman has no skills, has serious mental health issues, as well as developmental challenges. And then during COVID, they were out on their own. Some of those women had, for example, homes that they inherited from their parents, but because they couldn't pay the mortgage, they couldn't handle financial, they couldn't handle ownership, they were exploited. Some had their, you know, their assets taken away. So the city, you know, repossessed some of the home. Like there were so many banks possessed homes. Some of those challenges is like it's multiple. We have clients who are individuals who like Grammy winners, who not winners, not plural, but we had women who had successful careers, but because of mental health challenges, addiction, you know, then became homeless, live on the street. And when they tell you their story, you're working with them for 3 years, and then you find out their origin, their stories. You see, so it's a complex of many. We work with refugees, newcomers, we work with women who are diverse, you know, we work with trans women. So we work with that women identified group. Am I changing it to? Yeah, so I just wanted to start out. I know my colleagues spoke about Fred Victor, so I won't go into it. We won't give you too much Fred Victor propaganda today. Like you've had your fill, so I'll leave this alone. But we basically serve about. Did I move? So we basically serve about over 3,000 individuals a day across these programs that we've identified. And we work, like we have diverse programs, multiple programs. Yes. So Wes and I spoke about this in terms of like the cost of lack of access to services and what is an individual cost to the system. But we have about 10,000 people who are homeless in the city of Toronto. And that's probably more. That's the last data that I have. And it keeps doubling because the city is more expensive. It's there we have drug epidemic. And so that number will be doubling. So the cost of homelessness is 7 billion annually, according to 2013 report, and I am sure it's more expensive than that. So how's that cost? So one individual, they're using multiple systems. They're in and out of hospitals, so the hospital costs. So the homelessness and actually housing people is way much cheaper than what we have right now. Like we have, we know what the solutions are, but we need political will, and we need people who kind of the money is there. It's because we're spending it on in fixing and band-aid solutions. We're spending it on shelters instead of building homes. We're spending it on and people are out hospital beds, and we have wait lists, we have all of those things. So the system is like impacted so much in multiple ways. So we just need political will. So I just wanted to give you a little bit of a picture about who our population are and what is happening. So women's homelessness is basically, there are a lot of people, a lot of women, both young, old, and you know, in between, who are sleeping on our streets. They are sexually exploited. They face so many challenges. They face physical violence. Some of the women have you know, developed brain injury as a result of the violence and what is happening. Now, in terms of the drug epidemic that we have, someone can just take something, like people are changing so much and drastically. It's been impacting their health, it's impacting their sense of control, safety. We also have like a lot of exploitation in multiple ways. Could it be financial? It could be sexual exploitation, trafficking. This is a new phenomena that we're seeing with our clients, that we actually had to train our staff around how to recognize signs of that someone is involved. A client might be exploited and it involved in that. They squat in unsafe abandoned buildings or moving with older men who exploit them, like young. We're seeing more and more younger homeless individuals, and they are often fleeing violence at home and lack of safety, homophobia. We have a lot of young people who come from other parts like rural Ontario or other parts in Canada, and then they're lost in this city. And so in terms of the COVID impacted a lot about services, the pressure on services. It impacted a lot of hidden things came out. So it sparked increase in intimate, partner violence. It sparked intimate family conflicts. People who lived in smaller spaces, all of a sudden they were getting together and people could not stand each other anymore. So when someone has mental health challenges and then their symptoms, their access to health was non-existent. All of those things exasperated the need, exasperated the situation. So women aged 25 to 54 were twice that similar age with men to be working part-time and precariously worked. And that's like general, like even pre-COVID, but COVID even exacerbated that. And so reduction of services during the pandemic impacted people's wellness. It impacted, family dynamic. It exasperated all of the existing problems that already existed, right? So then there are senior women, and some of those situations that women are experiencing, there's like geriatric medical conditions where people who are in their 40s are developing those symptoms because they're on the street, they're not getting help. They're abused, their health is affected, they're psychologically scarred over and over and over. So that impacts their physical health. So they're showing geriatric symptoms, their memory loss, it's impacting on their thinking, it's impacting on their decision making, it's impacting on their physical health. So they're developing more complex health situations that should, like, not in that age, so the complexity of the individuals that we work with is high at multiple levels. Obviously, lack of housing and homelessness is also impact on health, like that social determinants of health that Dr. Iman talked about. So, and again, Sherry mentioned around the racialized women and indigenous women, single mothers, low-income women, immigrant women, and women with disabilities have a higher, they have lower access to services, and they have higher, as a result of trauma, racism, marginalization, all of those impact people's health, and they have lower income. And that got, again, exacerbated during COVID. So the homeless clients increased by 70% during the pandemic. This is not the city population. This is people with mental health and addiction that are accessing formal mental health services. So the request and seeing more of that population has increased at that time. So what is our solution? Like I'm kind of mentioned all of those problems. So what is our solution? Our solution is like that we have, Vasana mentioned this and Sherry, we have a model, housing first model. So what does it mean? The housing first model means that you immediately address the housing. Because when you house the individual, you don't focus on obviously you're working in that journey with them to stabilize, develop with them safety plans, support them to cope in the community. But what we do is we focus, laser focus on quickly housing people as quickly as possible so that they don't lose hope. They don't, so this is where the critical time intervention, I'm gonna go into it more. We also, I guess this is a very sensitive, like I shouldn't even get close to it. You know, so we also focus on appropriately housing people. It's difficult, it's not easy because we don't have housing options. But that what that means is if the individual needs high support, a place where you're setting them, if you house them in a place where they have high need, they need people to provide them support, and you house them in that, you're not helping them. Like, so you need to look at what is an appropriate housing, but also what support do you need to build in place? And that support that Vasna's talked about that integrated model, like how do you put support in place? So the person and their support, you need to do that wraparound support so that they can stabilize, they can keep their housing and maintain their health and continue in their recovery journey. So we also sort of support people in that critical transition. So when they move from street to shelter or from institutions, whether it's hospital or treatment, they have a higher chance of maintaining their housing. So you don't want people to be on the street. You want to make sure that you're doing that proper and quick transition. So our origin story, what is Hostel Outreach Program Hub is a program that started in, our history goes to there was an inquest that was done in 1986 because of the death of an individual, a woman, immigrant woman from South Africa who was a model and was in Toronto, developed mental health and addiction and challenges. And obviously in the 80s, as an immigrant woman in Toronto, she's socially isolated. She didn't have anyone coming to an environment in a winter that was different from that. So she died in the street of Toronto because she was turned down from the shelters. Because at the time, at that period, shelters were unable to deal with people with mental health and addiction challenges. So that inquest kind of developed then, why did this woman die on the street of Toronto? And as a result, a program, Ministry of Health established a program that is Hostel Outreach Program. So there was one that was established for men and there was one that established for women. We honor Dorina Chobart's history and legacy by making sure that this doesn't happen to other women. And so all the time we keep that in mind, we keep that history and why are we are here. And we want to make sure that doesn't. Then at that time, the model of the program was that the case managers' mental health were a bridge between the shelter and the mental health system. And so they did an actual street outreach to women. So if they see a woman on the street, they were outreaching to them. So they were walking at 6 a.m., going there to connect with women, giving them, and then taking them to the shelter. And then working with the shelter staff to understand that woman. Then the system changed so that there was a system transformation in in the early 2000s where the city actually developed its own street outreach. So we moved away from that street and we kind of became more focused on providing mental health case management. It's still working with with the shelters. So we had an original relationship with various shelters in Toronto, and we still keep those original shelters as that relationship. And then we moved to critical time intervention model in 2016, but formalized it really by training and developing the model around sort of in 2020. So what is that model? Yeah, so the historical overview of the critical time intervention model, it was developed in New York in the 1980s by researchers, social workers. There was a huge homelessness epidemic in New York at that time. And so researchers from Columbia University, and there was a shelter called Washington Armory Men's Shelter in Toronto, in New York, not Toronto, in New York, came together. And so they basically said, how do we serve people who are homeless? And what do we do? So then the researchers would study the intervention, and the clinician and the social workers and the street outreach workers will come together and then do these interventions, and then they put it into paper. They reviewed it. It's scientifically it's evaluated. It's a best practice, and it works in various populations. So now it's then moved to maybe working with veterans, working with seniors. Australia has a form of that with Indigenous population, for example. So that's how, so the focus is that critical transition of individuals when they come to the shelter or institutions, that you immediately support them and then house them, and then put the supports around that housing. So some of the can be like the people, when you're in a critical transition, when you're homeless, dealing with mental health, it's overwhelming. There's so much need. There are complex interactions of mental health and the social, what is happening in terms of poverty, homelessness, and all of those things, which kind of social connections are lost, relationships are lost. You don't have you're unsettled, and you're constantly in a state of alert, right? And so a lot of people, they're not gonna go and seek support. So you need to actually go there where people are and provide that support with them. So then you have to put the resources, you have to put the time in. And is my time, because I'm not.
No,
checking.
take your time.
So
Very
as I said, CTI is important, the outcomes, and there are tons of literature reviews. If you Google, you'll find all of that information. But basically what it does, that's proven like through study and seeing from our program, is it decreases the nights spent on the streets. It decreases homelessness. It decreases usage of hospitalization. It also reduces psychiatric symptoms and reduction of the amount of alcohol and substance that people are consuming. Reduction of money spent on substance, and reduction in days spent in jail. So these are all have been proven like through research. So what is happening here? Yeah. So what is the CTI? I just want to make sure I didn't skip one. Yes, I skipped. Sorry? I wanted to go to the one before. Yeah, after. Oh, okay, so I didn't skip one. I guess I deleted it. It's in my head, right? Like, so basically what CTI is when you, this is the supports, how it is. So the first one, the fully blue, means that when you're with the individual in the beginning, they're at that stage, they have no insight into their symptoms, into their mental health. They don't recognize the problem. Maybe everybody is the problem. Maybe the shelter worker is mean to me. My doctor, I don't keep appointments because they're not even helpful. I don't recognize I have addiction. I'm not gonna acknowledge that I have addiction. So in that time, the worker is doing all of the work. So what they're doing is, of course, they're working in partnership with the person and collaboratively, but you're searching the person, trying to keep that appointment going, trying to make sure that they're working with them on safety plans, working with them on harm reduction plans, working with them and connecting and engaging and making sure that you're also educating them and teaching them skills about their own symptoms, about their wellness, how to recognize, about you're breaking, you're kind of like getting them from the stage where they're not recognizing the problem to thinking, hey, maybe I have so maybe let me look at this. So they might in this stage, you're running after them, but they might talk to you for 10 minutes on the street corner, right? They're not gonna come to you, but they might actually give you 10 minutes and talk to you. And then you're trying to engage at that stage. And as that engagement, then they take on a role. So this time they're talking to you. Next time they might tell you, hey, I need this, right? And then, so slowly, the person is taking charge on their own recovery. So next time, instead of, you might only need to remind them about the appointment instead of accompany them and taking them to the appointment, right? You might call the shelter worker and say, remind, this person about the appointment, right? So as gradually your interaction with them lessens, and then they reach at the end where they are the lead of their own, right? They're connecting with other service providers. They're doing this, they're going to their appointments. You've set up maybe if they need injection, if they're following on their harm reduction, they're managing their tenancy, they're managing their symptoms, they're managing financially, they're spending less and less on addiction, they're budgeting, they're recognizing, they're seeking support, they're engaging with their social support networks, they're building relationships, right? So that's when we then you walk away. So there are several 4 phases. Well, actually there are 3 recognized phases. So the pre-CTI means before the CTI starts, what you do is that's the engagement space when you're looking for people, when you're connecting with them. And then phase 1 is transition into the community. Remember how I said quickly housing people? So when you house them, that's when the CTI starts. So you house them and then you provide them support 1 year up to 1 year. So in the first phase, phase 1, which is transition to the community, that's when you as a worker, you're doing community mapping. You're connecting with them and say, hey, let's walk to your neighborhood. I saw a drop in there. There's a church that provides meals on Wednesdays. You have your shopping here. You actually go to the market to shop with them and then say to them, okay, we're gonna go shopping. You're at No Frills. I'm gonna just follow you around. Why don't I spend your money, like shop, buy the things that you need. So what you're observing is how much of that money goes to like snacks, how much of that money goes to other things that are not nutritious. So you're looking at and then you sit down with them and say, so you know what I've noticed? You bought this, and you spent half of your money, right? So then that's how you start the engagement. You're trying to create a community for the individual. Most of the homeless are in downtown, so when we move them to Scarborough, you want to create a community. You want to create a neighborhood. You want them to get to know their neighborhood. So in that period, in that phase, you're seeing them 3 times a day. 3 times a week. The first day in the community, you're spending full day with them in the community. And then you're looking at daily living skills. You're testing, you're looking at, then you're gonna explain about tenancy rights, about how to maintain, how to manage. You're developing a plan with them about managing their tenancy, connecting them with the support in the area where they live. Because if they're traveling to downtown for their support, they're not gonna go, right? So you wanna make sure that they have a lot of support in where they live. And then you move, that's generally about three months, that phase. And then you go to phase 2, which is try out. Now you connected them to the community. Now they're trying out other supports. So you're connecting, you're meeting with other supports together so that they can build trust and they can build connection. And so you're seeing them less now because now you've kind of spread out their support, you're seeing them less. The important thing is, and Vesna talks about this and Care, is that strength-based recovery. You want the person to take charge of their own recovery. You don't want them to depend on you. It's easy to depend on you, right? So you're seeing them less frequently, and then the phase 3 becomes even fewer contacts because now they have a relationship with someone from let's say Scarborough Center for Healthy Community. That's where they're going. They have another relationship with the nurse practitioner at the hospital. So you're trying, but in that period, what happens is then the client, so from the start to the beginning, you're telling them about the transition and that you're stepping away, you're explaining. And in each phase, you develop a plan with them, a care plan. So part of that plan focuses on 3 areas around tenancy management, mental health, emotional and mental health, and managing addiction, managing money, managing tenancy, and daily skill living. So you're doing those 6 areas. Each time you're developing a plan with them in 3 areas in each phase. And the client kind of works with you around that. And then next time you evaluate and say, hey, where are we? Here's what we've done, so that it's not shock to them that the service is gonna end, right? And then the phase 3 is transfer of care. So fewer contacts, hands-off meetings, you're talking about the transition. And so each phase is 3 months. Sometimes the person might decompensate, like, right? And then so you might go back a little bit and kind of revisit some of the plans and some of that. There are obviously people that you cannot transition in that fast because they need a higher support. So in that case, sometimes until we find that service, we keep them. And one of the things we also say to people is, like, if you find that your plans are not working or there's a breakdown in relationship, just call us, right? You don't have to go through, that process call. And then we might work with you on a short term for 3 months, right? So hopefully, so this is basically what our model kind of, we get the referrals, and the referrals, the individual can come to us. They can come from any shelter workers, hospitals, anyone like will kind of refer family members, neighbors. We had city councilors refer to us people. We have actually, funny enough, we have people who self-refer, but they say, hey, my worker, my friend in the shelter has a hub worker and I want a hub worker, because I see what they, how they work with them. So we get a lot of that. So then in this model, we have a housing worker. So housing worker immediately starts housing search. So the first time the person refers, the case manager, the primary case manager will do an assessment. And that assessment focusing on housing and tenancy. So you're supporting the individual to build those skills, even though you're in pre-CTI. And the housing worker immediately starts working with the individual. And sometimes they're not ready, so they'll tell you, I don't want to meet someone else, right? And then the phase plan starts. And then when the person secures housing, we go to that process that I explained to you. Yes, so basically it's, by the way, this is, I got permission from this picture, a former worker, a hub worker and a client. And so we strive to support women to succeed and to lead their own recovery and to provide them as much support as they need so that they can live in the community with dignity and get the support that they need. And so we strive to work with them in that walk alongside them in their recovery journey. And part of the things that we really try is that low barrier, the client leads where they're at. We work around like that stages of change. So each stage, if the person is already in action and they're ready and they're, you know, whatever, you work with them at their pace. If they're pre-contemplation, you develop your strategy around that. If they're at recognizing the, like, so you, in each stage, it requires a different strategy and different a way of working together. So in sometimes you might just work with them around just making sure they're safe, just making sure that they're actually safe. So they're staying on, you know, those conditions I told you earlier about. They might be staying in an unsafe place with a man who is abusing them. And they're not there to be moved from that. So you work with them to make sure that they develop those skills, right? And be safe. Thank you very much.
Thank you very much, Decca. That was a wonderful, important information, and it seems like it takes a it's very integrated, all the services. You work in silos, but at the same time, there's the big picture, and you all have to come together in order to help someone go from, you know, lack of housing to then becoming part, going back and being supported by the community. And it's really all about autonomy, isn't it? Where they can then stand on their own 2 feet and begin to move forward with the support systems that are there. I would like to invite Eamon back, and she would just like to have some closing remarks for the presenters, and then we're going to go into a quick Q&A session.
I never stop being amazed
Yes.
at the breadth of work that Fred Victor is doing and the depth at the same time. I never been amazed at like how comprehensive our programs and support programs and the work we do. And then how we transfers from the macro level at decision making and working with the city, political entities, and also going all the way down to the grassroots level and working with individuals on the streets from all parts of life. I think I'm blessed to be part of Fred Victor. And you have informed me a lot today of how to go on about my role at Fred Victor, how to develop inclusive developmental and investment housing strategy that can embrace all those successes and actually support it to become bigger and bigger again. I see not only the comprehensive and traversing about the macro level and the micro level, but also across housing continuum. So if you look like you are taking somebody from the street through shelter system, through transitional housing, grooming them to support the affordable housing, till they become homeowners at one time. So I think this is amazing. And we need that to reflect on like what's happening in each side and then how we can, like go back and forth and have like some collaborative work to see individuals going and through that. And as you mentioned, Dika, from complete dependency on support to absolute autonomy and also independence. And that takes a lot from all our departments, especially with your investment in that accord. But if we are now, the focus is women and housing, I'd like to call. Okay. So if we'd like
Going forward to the
to
mic.
focus more on today's event of women and housing, I'd like to call upon, I think, when we put women in the center, that means like we want to make the invisible visible. And then that calls, to my opinion, for redefining homelessness. But all the stat here is showing people on the streets. But we all know that there is people who are in houses, but they're still homeless. So I would like to call upon all people who are concerned with homelessness and combating homelessness, especially for women, to redefine homelessness and give it a gender face. And that I suggest, and of course the list can go on and you can all contribute to that, is by at least having our collective data integrated, gender disintegrated. So when we say like, I like what you mentioned, for example, Shirley, when you said like 699 women are pushed back. So why? And then how much is that for the comparable to men? Because if you go to the stats, sometimes say most of the homeless people are middle-aged white men. And that's not really, I think, representative to those who are living in abusive relationship or maybe precarious conditions, which we can call that, or maybe very low paid job with a market increasing, so they're all exposed on that in a way in the verge of business. So this integrated data by gender. And I would like to call also to take it further down by looking at the intersectionality within the gender groups. Like we are talking about seniors. We talked about the youth, the missing middle. We talk about aging in place, and aging in place can be like somebody from being middle-aged to become senior. So they need different kind of support. But also we have seen some families who are living in our housing and their kids transferred from being children to teenagers to now become adults, but they're still, invisible. And then among that, now again, we look at now our disintegrated policies. When we talk about the immigration, we are opening our country to immigration, and that's very kind, I think, from government of Canada, but it really needs to be harmonized or integrated with housing policy, with employment policies, so that they don't burden the systems. And then we are well prepared for receiving these people in the dignity and dignified way that we wanted to play in our society. And at further breakdown, I'd like to call upon people who are more knowledgeable than me on mental health. Mental health is just a sweeping blanket, but we need to look at mental health different categories, and so that we can target the different levels of mental health recovery. Thank you very much. I just I feel amazed continuously, and I would like to invite my colleagues here to just help me and also support, invite them here, but also like them to help me, giving me your needs. And I'm asking you, how can I help you from my position to support the great work? Thank you very much.
You can sit, yeah. Thank you very much, Eamon, for that summarization of all the presentations. You actually did my job. You did it very well. Thank you. I would like to now open the floor to both our in-person audience and our virtual platform in regards to any, if you have any questions or you'd like to raise some concerns or raise some issues. Yes, please, if you can come here so that our audience can listen as well, if that's virtually.
I actually have two questions. So I saw very impressive model that you have. And I was wondering for the 40 Oak Street, is it possible to use that as a first intake site for all your other sites so that you can give them that level of care before they're sent out to like the appropriate place from where they need to be? And the second question was, do you have enough CTI staff or 40 Oak model staff to serve more clients, for example, if the shelter was there? So you mentioned that the CTI is the step after their shelter, right? So I'm looking on the building side, I'm a carpenter, and I'm trying to get more stuff built. And there's a lot of women carpenters, especially 70% fall out of the trades for various reasons, especially in carpentry. And they do that at a lesser percentage for all the other building trades as well. So you've got a huge population of people that want to build. And so if the housing, like putting the housing aside, if you already had the housing, would you have enough staff to serve them, like through the CTI model? And also, because I know that because there is a lack of mental health accessibility and professionals, are there enough people that are educated to serve, or do you need like the youth to start, you know, becoming mental health professionals to serve the demand that the community?
Thank you.
I'm gonna try to. Who would like to answer those questions? Who wants to answer the first part? So the first question was around access, well, assessment and access to other sites using 40 Oak model. So I think I want to answer it going back to one of my first point about homeless population is not homogeneous population, and that there are various levels of access that we need to consider when serving people in need. So for example, DECA was talking about her reports was from central intake, and that is a central access to case management and housing for people with living with mental illness. But not everybody is able to, you know, go and go through that kind of a streamlined type of intake, so to say. So that means that a more low barrier access is needed. For that reason, we have programs like the one that DECA was talking about with critical time intervention for people that are homeless, but also for people that are just leaving hospital, for people that are just leaving jail. Those are that's why model is called critical time, because those are the critical times where you need almost like catch opportunity when people are susceptible to seeking help, especially those that are chronically have been service users. With another level of low barrier access and assessment are our drop-ins. So when people have enough of, you know, they don't know what services are there. They don't know what kind of help they want. They're lonely. They heard from somebody, this is the place where I can go. They have a friend whom they've heard uses drop-in services. So that is one level of self-initiation, but also outreach by drop-in staff. With respect to the 40 Oak itself, one way to manage or to identify what kind of services are needed is focusing on that particular building on that particular community because every building is different and every community is different. So that the model that we build just for that community, just for knowing what are the issues and knowing what people need for how long and what is the mix of staff needed. So I hope that answers it.
Just, sort of Vasna covered that piece around different population and with different needs require different services. And so if I could give you an example, one of my programs is there's actually going to be this Friday an announcement of housing, affordable housing announcement by the Federal Minister of Housing at Bridgemount of that building. So there's a building at Lawrence and Bridgemount Street. It's a model of mix, and I hope it has its own challenge. Each model has its own challenge. But so that model is the building is about 220 newly built full purpose green. It's called Bridgemount Green if you want to Google it. It has 220 or is it 270 units? About 100 of those units are to homeless people who need affordable housing. So it's a market rent. Canada Mortgage Housing Corporation pays the supports people to kind of so they can afford. So it's a rent to geared income. We have about 32 units in that building, and so we have staff there, and it's families. So it's for families with small children who are homeless, and who've been chronically homeless in the shelter system, and single individuals, but history of homelessness. And so that place has staff on site that provide support and make sure that so there's groups, skills. If children who grew up in a shelter, their socialization, there are challenges to that, right? So you have to tailor your support and services to that particular population, So there are so many different in the housing continuum, different models, but each model works for a particular population. In terms of your other question around, are there enough people to provide? No, there aren't. There are so many people on the wait list. There are so many people who could be getting the supports that Vesna's programs offer, my programs offer. There are so many people who could be getting into the shelter system, but we don't have enough of resources. We don't have enough supports.
Actually, that leads into my question is, it's obvious, yes, there's never enough supports, especially when it comes to mental health and addiction and just the basic needs that we as individuals need in our community, housing is being number one. And of course, you don't have housing or you're displaced. It's like any other with refugees. I mean, once you're displaced, we're holistic. It affects our mental, our spiritual, our psychological, our physical well-being. I mean, people get, stress. Stress is a huge indicator for ill health, whether it's mental, physical, or spiritual. And this brings me to the question of the lack of political will, like you said. I mean, it's basically shelters are a Band-Aid. There shouldn't be a long-term, it's becoming more and more long-term, and the burden is becoming more and more on shelters and case management. And, what should be just like a 24-hour thing is now becoming, 1 year in order to get someone back in a position where they're standing tall, they're on their own, they feel that they have enough support systems around there, and they're moving forward with their life. They're autonomous, they're independent. So my question is, why is there this political, the lack of political will, and how can that be changed? I mean, obviously, there's policies, why is there this political unwill? Or politically, a lack of will? And I know that's a very complex question. It's not an easy question. And I think number one is, you know, I don't know, votes. Is it not the sexy question right now? Like,
So, to answer your question, before pandemic, before Ontario, Ministry of Health in Ontario implemented a structured psychotherapy program, they had a consultation with agencies like Fred Victor how to implement psychotherapy with homeless population that is evidence-based because there's many therapies around. And not all are as effective, and they're effective for different things. And there's a lot of new evidence that is coming out. And they brought in as consultants two people from the UK who effectively enacted mental health strategy and services for the Great Britain for their health system. Two men. One is a politician, and the other one was a psychiatrist. And two guys single-handedly turned around the whole mental health system and the way how they provide psychotherapy for the Great Britain. It can be not so complicated.
true.
And you know, I'm not in politics, even though you know, we have to entertain ourselves with politics because it influences every single aspect of our life. And it is, there is evidence that it can be rather simple. I think it makes me think about barriers we need to remove as services to get our message across, being more sophisticated about data. And because typically all the resources that are brought in, especially in the community sector, go to services, not into fancy presentations. And so, but we need to think about this more strategically, how to deliver good quality data to decision makers about a problem and about the solution that is measurable and effective. And so that's what we've heard from our partners from Great Britain, that it was the evidence brought with credibility to a politician to move things forward.
Oh, very interesting. And who's doing that data, or who's accountable for doing that data? Is it the regional, is it the provincial government? Is it the federal government?
Service providers.
Okay, very, very interesting. Fazila, and then, I'm sorry, Allison. I also wonder, is there anyone online that's, okay. And then after that, we'll do closing remarks.
Thank you so much. Just, I wanted to thank Fred Victor with that amazing job that you are doing. I'm really amazed. And I admire your job because you are helping us to see less and less homeless people in the streets, which is very sad to see people around the street without any shelter. I wanted to ask a question that, you know, what is, you know, you are doing a great job during bringing people from the street in the shelter and the amazing services that you are providing for them. My question was, what is the next step from this, you know, from the shelter to the community? But I got my answer from Deka's presentation in that three phases. Something that I I didn't hear from you, maybe it's a gap, maybe it's not presented here. The relationship with the labor market, because we know that homelessness is an intersectional issue. And economic empowerment is the essential pathway to, empower people and let them to provide a shelter for themselves. What is your relationship with the, for example, business owners, with the labor market? Do you have any professional training to facilitate their access to job or employment? This is my main question, and something that I wanted to make sure that in the pavilion, we will, document these narratives, very beautiful and strong narratives to the global level, to transfer these stories to UN Habitat. And I think that with the global communication, we can somehow overcome these issues and find the best practices and solution for these issues. Thank you very much. I just wanted to appreciate your work. Thank you.
So in regards to the economic empowerment of training and jobs. So Fred Victor is a multi-service organization. So one of the programs that we have is also employment and training, and we have food security programs. So one of the things that, but because of Fred Victor cannot serve the city of Toronto and all of the clients that we have, we also connect with other service providers. So for example, when we say that the client needs and their need leads the process, is like some clients might want to have employment and right away. So for example, we've seen recently in my programs, a lot of refugees that are coming, who are homeless refugees seeking support. They have work permit, they're very eager to work. So part of what we do is we have developed some resources around service navigation, just to help them with that training. So there are multiple programs across the city that provide that training. So when we work with an individual, we're doing a holistic assessment of the individual. If their goal is employment, we're going to support you and work with you on that employment. If your goal is education, we're going to work with you and support you to get that. If your goal is to have a small business, we have like, so the case managers they are detectives, they are, counselors, they are mentors, coaches, they are also like resource developers. So you learn to have, to know what is happening in the city, the pulse, what are the new programs, what are the new subsidies, what are the new, so you're constantly informing yourself so that you're able to address your client need.
Wonderful, thank you. It really does take a village, doesn't it?
Yes.
And our last question.
Thanks, folks, for all you shared today. My question is in relation to gender diverse people who are accessing Fred Victor services. I asked this question kind of in some of the last 3 days of this conference. We're talking about women and gender diverse people, but all of the best practices we're discussing are women. And the services women are accessing and the stats we have specifically on women has been, by far the focus. And I come at this working in the field as well here in Toronto, and not knowing like what I can do better and what we can all do better. So wondering if you have certain programs or best practices that you're using or ones you know of or are wanting to implement, and how we can all move forward with this.
Thanks. Thank you for the question. It's a really good one, in my view, and it's certainly something that, and I can really only speak for the department that I work in emergency shelters with a little bit of information in terms of, agency-wide. So I guess for starting agency-wide, the issue of gender diversity is something that we look at through we have an equity committee, equity, diversity, inclusivity. So certainly that's work that's happening at a higher level. In terms of within the shelters, it's been a growing process for us, absolutely. 3 decades ago, when I was working frontline in shelters, the number of folks who would, outwardly identify, well, people just weren't identifying as non-binary. It wasn't part of our language. We would occasionally get women in the shelter who identified as transgender, and they were treated horribly. Let's be honest about that. So it's been a lot of work that has had to take place. And I think the key piece is training of our staff, training of our managers, training of our senior leaders. And also coming together as a sector to talk about how do we best serve this community in the most dignified and supportive way. I'm not sure if I've answered your question, but my little bit about that. But it's critical, and how we deliver services has had to shift in terms of getting away from this very narrow definition of gender and what it means to be a woman or what it means to be a man, moving away from that. And people individually are at different places in their own skill level and, ability to do that.
So we focus on the individual, right? Like obviously in any work that we do that looks at as the human in terms of whether they have the gender identity, sexual orientation, age, race, ethnicity, immigration status, social location, all of those things impact the individual. So the goal is like, how do we make our service accessible to everybody that preserves and respects the dignity of every human being that works at our door, and that everybody receives the right service. And so part of that is what we've talked about. And as an organization, one of the things that we've done is we looked at our own intake forms, and then we changed the language that we use. So HOB, for example, established for women, but now we say women identified, right? So it's for women identified. We have programs, other programs, multiple programs in each of our departments that serve trans, that serve women identified, men identified, immigrants, refugees, newcomers, people who English is not their first language. And at every step, we have to really look at it from an health equity and access. So one of the things that we can do as a programs and as an organization. So from the senior leadership, what we've developed is the equity, sort of the equity lens, where we look at programs, are we serving the population the way we need to serve them? Thank you very much.
In closing, I would like to extend my heartfelt you have a question? Yeah. Yes, come. It can't go.
We can repeat it. You can repeat it.
Oh, yeah.
Yeah, they can't, you'll have to come up.
Just repeat the case. I still, last line is, we talked about areas. And you just, I'm not sure. The plan saying phase. Although measure for science show. So they do this, why was it? So this, it was leaving for, like, look at it. To be honest. Access to. Absolutely.
Okay, the question, sorry, I'm just gonna repeat the question for our virtual guests. The question was, is there Islamophobia, correct? And how is that being addressed as a barrier to accessing housing or into dealing with homelessness?
Right, thank you. Thank you for the question. It's a good one. And on the listing in terms of things that that sort of the reasons why, the issues that contribute to women and gender diverse people becoming homeless wasn't an exhaustive list, first off, but I would have included Islamophobia, anti-Semitism, anti-Indigenous racism, anti-Black racism, all under the heading of racism and anti-oppression. Absolutely, we have Muslim women in our programs, in our shelters, and our staff, and they face barriers and challenges, and in the same way that
it's kind of taking the house and they told me it's not participating, just to show that I was easily to see organization assisting so we include those problems in terms of quality. We even include in terms of challenges, decision making, just to show, oh, no, we don't really find out some of the vision, some of the just listen to that quiet, they want that, it actually they don't need to be included. Because honestly, I was lost vision for this insight. Script. Why they are here? The only thing, at least in how that's not vision. So the living language. So what goes into the here? So why it's really is even if it's facts, it's nothing. So I would love it next time we send this.
thank you for the feedback.
Well, I just wanted to ask how are partnerships with the community made? Like if there are people out there in the community that want to help or have some solutions, how do they go about, connecting with you guys? Is there a certain contact that we need to? Sorry?
Website, on the website.
We just go on the website and.
Yeah, and it'll show you exactly how to get involved.
Okay.
Yeah.
Thanks. Wonderful. No more questions? Okay, so now we will do the closing. I'd like to thank our heartfelt guests, speakers, Sherry, Vesna, Eamon, and sorry.
It's Vesna.
I'm sorry, that's why I got who am I missing? Decca.
They mix this up all the time.
Your insights.
We'll interchange.
That's right. We all are.
We're
We're just women.
we think alike.
Yes.
Yeah, alike. That's the energy of something.
You tapped into something they're
Yeah.
not being.
That's wonderful. Thank you for your wonderful presentations and all the information that you provided. I have learned a lot today. And I'm sure our audience also has learned a lot. And it is something that I'm more I want to learn more because, you know, shelters are there and the programs, and I'd love to even hear the stories, like that puts the human face to it, you know, because then you really see the hardships and the work that you do in moving them forward. So, and I know you have those stories in your website, so I definitely ask everyone to go and look at their website. I've seen some of the stories and they're very, very inspiring. I would also like to thank our participants who came both in person and virtually. And as we conclude day 3 of the Urban Thinkers Campus, let us carry forward the knowledge and inspiration that we have gained today. Together, we can continue to advocate for and implement effective solutions that make a great difference in the lives of those that are most in need. Thank you very much. That was wonderful. I really, really enjoyed your presentations. Yes, yes. Please go ahead and have coffee and tea. There's lots. And I'd like to have a picture. Priscilla, I'd like to have a picture with you and us from UEM. Okay?